Professor Emeritus Malcolm Sim, AM, is a globally respected occupational environmental physician, and he led the Monash University Centre for Occupational Environmental Health in Australia for many years. And I should say, it's quite something for someone like myself who spent 22 years in Sydney to be introducing someone from the other place. But I'm delighted to do so. And of course, Monash isn't the University of Melbourne, so even more impressively. But seriously, Professor Sim has an incredibly distinguished career, very important work, and thinking about, as we'll hear, the work around silicosis in particular has been so important. His research has been focused on identifying workplace hazards and preventing occupational diseases, including cancer and respiratory illness. He's played a leading role in tackling Australia's silicosis epidemic among stonemasons, which has been a massive issue in Australia and elsewhere, and has held key leadership roles in international organizations, including as editor-in-chief of Occupational and Environmental Medicine and president of the Faculty of Occupational and Environmental Medicine in the Royal Australasian College of Physicians. And in recognition of his contribution, hence the honorarium at the end of his title, he was appointed a member of the Order of Australia in 2019. So it gives me great pleasure to welcome you, Malcolm, to Manchester and invite you to deliver the Lane Lecture. Thank you so much.
Thank you, Duncan, for that very nice introduction. And yes, there's a little bit of Melbourne-Sydney rivalry there that you can see. In fact, more than a little bit. But anyway, we'll put that beside us just for the moment. So look, it's great to be back in Manchester. I can see that you turned the weather on for me this morning. It was pelting down with rain, so I really appreciate that. But I see looking out the window that the sun is now shining. So there you go, things are looking up. And it's always nice to be in Manchester. I'm a great cricket follower, and I know the Old Trafford ground, which is very nearby. It's the scene of many famous Australian victories over the English cricket. 2019 in particular, although rain saved you in 2023. And look, it's a great pleasure to be asked to give the Lane Lecture for this year. I've been, and in particular around the 80 years since the department was set up. It's had a long and distinguished career, so it's a great honour to be here for the 80 years celebration. And I've been doing a little bit of reading about Ronald Lane. I read a couple of his bios. He lived to the ripe old age of 97, which is pretty amazing. But he had a strong interest in preventing occupational disease from workplace exposures, and also promoting medical input into decision making. And there are two aspects of occupational health that I've got a particular interest in. So it's a great pleasure to be here to do that this afternoon. Now I'm going to take you through this really major issue that has occupied us over the last 6 or 7 years or so, getting to the point of a total ban of artificial stone. But it's a whole journey. It's not just a one-off event. And I think it's really important to understand the lead up to that and what's happened subsequent to that event as well, and the wider implications. And many of us who've been involved with this journey have been speaking at international fora like this one to try and get across some of the lessons we've learned, and hopefully other countries will pick up, because we are not unique with this particular problem. Now, I've got 3 microphones on, so I hope you can all hear me okay, and we'll see how this works. Now, I don't usually show holiday snaps when I give talks, but this one's particularly resonant. This is me on the island of Kos, a small Greek island off the coast of southern Turkey, and this is the birthplace of Hippocrates, as many of you are probably aware. He lived and worked there, and of course everybody knows about the Hippocratic Oath and the various principles of medicine that he espoused. And one that is on the back of this particular statue is about prevention is better than cure. And I think this applies very much to the silicosis problem that we've been seeing at home. And I suppose it's not a fair contest, though, is it? When there isn't a cure, then it's much easier to be promoting prevention. And there certainly is no cure for this particular problem. So look, what I'm going to talk about today is about artificial engineered stone and some of the unique aspects of it. It's not just another form of silica. I talk about the health effects. Most of you are probably well aware of that. I'll skip over that pretty quickly. But it's around the rise of this epidemic of artificial stone silicosis in Australia and our journey to a ban, because it is a whole band going through a whole range of decision points that have been really important. I want to then talk briefly about the international experience and then focus on what's been happening here in the UK and hopefully give you some pointers to try and avoid some of the mistakes that we made in the very early stages of this particular problem. So artificial engineered stone, some of you have probably got these in your houses or apartments or whatever. Very popular. It's a kitchen bench top substance that's really overtaken natural stone in terms of scratch resistance. It's got the wide range of colours. It's got lots of advantages over that, and it's cheaper as well, which is really important for homeowners who are looking at building a house. And it's very strong. It's got 4 times the flexural strength. But the important thing is that it's up to 95% silica. And while people focus on this, which is a really important characteristic, the other important aspect of it as well is that it contains a whole array of other binders, polymers, pigments, metals, and other additives that make up the other 5 to 15%, depending on the silica constituent of it. So I think that's a really important aspect of this when this is being ground, sanded, and drilled. That is also a range of different airborne contaminants that are given off as part of that process. Now, I've shown you the glamorous end of the artificial stone business. This is the less glamorous end. This is often done in very small workplaces. This is the top picture is outside. Most of it is inside. You can see that it generates a very big plume of dust that comes off that. And this is a picture of somebody at the end of a work shift. You can see that he's covered in an array of dust there. This is done in small workshops. It's a large immigrant workforce, and it really runs under the OHS regulatory radar. These small places, I mentioned this before in the panel, usually poor hazard control, no health surveillance, nothing, and often workers who don't really understand the health and safety regulatory environment either. And of course, this is a lot of this finishing is done in the houses themselves. So these workers are trying to do the right thing. They don't want to get dust in the rest of the house. So what do? They cover themselves with a plastic sheet, which makes it into a confined space. You can see that there's a ventilation hose sort of coming through there, through the window, probably completely ineffective. And the guy on the left has got a paper mask on, again, completely ineffective. So these are the kinds of work environments that we're seeing in this industry. And look, this generates really high levels of airborne silica. This is some work that was done from Sydney, and it shows that with dry cutting, the dust levels were 44 milligram per metre cubed. Your workplace exposure standard here is 0.1. Ours is 0.05. But you can see that this is orders of magnitude above what's safe to work with. And even on the left-hand side with water suppression and local exhaust ventilation, they're still well in excess of the workplace exposure standard. And there's some recent work that's been done here in the UK as well that looked at, there's a controlled experiment in a laboratory, but wet methods were the most effective. But local exhaust ventilation may in fact hinder the effectiveness of the wet methods. So, and of course, this is in a laboratory situation. It's quite different once you get out into the workplace and see what people are actually doing. So why are we concerned about silica? Well, it causes a range of different diseases, and we're focusing the talk today on the silicosis problem. There are different phases of that, as you're probably aware. If it's left unchecked and people have continuing exposure, they'll end up with PMF, progressive massive fibrosis, which is a terminal disease. But it also causes COPD, so the chronic bronchitis, emphysema, and it's a group 1 carcinogen as well. It's been classified by IARC, the International Agency for Research on Cancer. I've sat on a few of their monograph meetings, and that was decided to be group 1 many, many years ago. Also, it makes people more prone to tuberculosis, and this is very important in terms of an immigrant workforce in particular, where we know tuberculosis is much higher, but also the autoimmune diseases that makes them more prone to that as well, and of course kidney disease, which are a longer term problem that can occur in these people. So what about the science of this? When did we start to think that there was a problem? This is a paper published in Chest in 2012 by an Israeli group. And interestingly, this is a lung transplant group. So these are patients who were referred here for lung transplantation. So they're right at the end stage of their pulmonary problems. And most of them died because they're not good transplant recipients. The hardening of the lungs makes it very difficult for them to be removed. They're not good candidates. They've usually got other chronic problems as well. But this should have really raised a flag, a big red flag, to say, look, if we've got workers getting to this point, it's so severe that they're candidates for lung transplantation, we really need to look at the work practices for this particular substance. But of course, that didn't happen. The first Australian case report was published in 2015. This is by Debbie Yates, originally from the UK, who now works in Sydney. And she and colleagues put up this at the European Respiratory Journal. I think it was presented at the conference that year. And this was, of course, the interesting endnote of the title, an embarrassing first for Australia. But of course, it wasn't the first, but it was certainly the first case report from my country. But again, this did not lead on to any form of further investigation or investigation. Now, you know, we're taught when we do Epidemiology 101 that case reports and case series aren't, you know, don't tell us much about causation, but they can be really important signals for something unusual which hasn't been adequately investigated in the past. The first case series of this was in 2017. And this is by Ryan Hoy, who's a respiratory physician in our group at Monash. He published a case series of 7 affected workers. This was in 2017. I was editor-in-chief of OEM at that point. We put it through expedited review, still goes through proper review, but we just do it in a very quick way. Can't remember who the reviewers were now, but we published this. And again, this should have been another really important signal that there's something important going on here. And when you look at these 7 cases, what we found from the information that were collected from each of those, they were all using dry cutting, so no wet methods, no local exhaust ventilation. 2 of them were 26 years of age. Now, this is quite different from what we know about the demographics of usual silicotics from other sources of silica exposure. This is a really young age. Usually it's people towards the end of their work period or even retired who are going to develop it from other sources of silica. And the period of exposure as well, you can see here in that second column, quite short. We had one of these cases only 4 years. So this is showing that this is quite a different situation from other forms of silica exposure, leading on to very progressive impairment of their respiratory system. And of course, none of them had been involved with any health surveillance, even though this is a requirement under our health and safety regulations, under our legislation in Victoria. So this started to get into the headlines. The media started to get interested in this, and this is a case that was highlighted. Anthony White, who was only 36 years of age, and he'd been diagnosed with silicosis, and he agreed to be interviewed for one of our television programs. And this is a fairly confronting photo, if you're not used to this sort of thing, on the right, taken, whoa, that seems to be flicking on before I wanted to. Taken just weeks before his death. So this created quite a large interest in the media and in the population more broadly. And as a result of this and some of that initial work, I think part of the problem we had at that stage is we'd had a demedicalising of our occupational health and safety regulators, both our Safe Work Australia, which is the national body equivalent to your HSE, but each state and territory also has their own regulatory framework. And over time, the medical input to that had been had been let go, if you like. That aspect, we didn't have input at that senior level into these organisations to raise a red flag. So this really fell to the health and safety professional bodies, and through the College of Physicians. I was president-elect at the time of the Faculty of Occupational Environmental Medicine. But we pushed heavily and sent a letter to the minister, the federal minister, to say this is a really important problem. We think a task force should be established to really investigate this in depth, consult with the regulators, with the employers, with the trade unions and the clinicians who are seeing these problems, and get a better handle on what's going on and what the options are for the future. And the minister agreed with that. We were very fortunate about that. This is a couple of ministers ago. But he did set up the task force, and importantly, it contained several clinicians. It had occupational environmental physicians and also respiratory physicians, as well as some regulators and other stakeholders in the industry. And at the same time, we approached our state-based regulator, this is WorkSafe Victoria, to saying, look, we need some evidence here. We need to have a handle on this to give to the task force to try to determine how big a problem this is. So they agreed to do a rapid screening service. We set it up with 2 occupational health providers, and we made sure that we had highly sensitive methods that we were using in that. So we didn't just use simple spirometry, we had diffusing capacity. We used low-dose CT, which was emerging as the radiology technique of choice. And we had a quality control procedure built into that as well. And there were some learnings out of that because we'd done a review of the emergence of black lung in Queensland coal miners about 2 or 3 years previously, and it highlighted a whole lot of deficiencies with the health surveillance program that had been going on at that stage. So we were really pleased when WorkSafe decided to fund that, and it was open to any stonemason who'd been working in the area with a focus on artificial stone. Once we started doing this, very quickly, we found that there were 86, in the very first phase of this, 86 workers that we identified with silicosis. So this was clearly far more than the 7 cases that had been highlighted in Ryan's case series just a little bit before. And as a result of this and other information that was coming through at time that the task force gathered during its deliberations, and of course it was interrupted a little because of COVID. You can see it was set up in 2019, a report in 2021, so it did get a little bit delayed, as most things did at that stage. But they came up with a so that was June 2021, and they came up with this final recommendation that commenced, if they looked at a whole range of ways to try and reduce dust within the workplace, to try and improve dust control methods, improve health surveillance, improve monitoring with these very small workplaces. But if that didn't show some measurable improvement over the time up until July 2024, they recommended that there be a move to ban this substance completely. And of course, you've got to remember there are lots of substitutes for artificial stone. There are lots of others. Maybe they're a little bit more expensive, maybe not quite as strong, maybe not quite as pretty, but there are lots of other examples of other substances that can be used. So this was the final recommendation of that particular task force. Now, we kept doing our screening. We found that 25% of the people who we were seeing had silicosis in its various forms, but even more importantly, almost 80% had high exposures. Our hygienist who works with us, Debbie Glass, who I think some of you know, put together a risk matrix and used the information that we collected at the questionnaire stage of this screening program. And we found that they had very high things. They were dry cutting, they weren't using exhaust ventilation, they weren't using protective equipment at all. So we're going to see a continuing burden of these cases over time, we believed. 85% were using dry cutting, which had been banned for some years in Victoria, but of course people were still doing it. We then, Ryan and I, put together a compilation of the statistics from around Australia soon after we published that other paper. Now, some of this was from, or most of it was from unpublished sources. They were reports rather than published papers, and there's a little bit of rubberiness about some of these figures, but it shows you the sort of burden that we were seeing even at that stage, late 2022, almost 600 cases. So just picture that for a minute. We had a first case report in 2015. We had a case series of 7 in 2017. And by late 22, we had almost 600 cases from around Australia. So this shows you how quickly this condition can impact on a large number of people. Now, we're sure that a lot of people had been missed in earlier stages, had been misdiagnosed. We have a lot of anecdotal reports about people being diagnosed with sarcoid or COPD, some other condition, and they didn't get asked about work. So there presumably were many more cases than that, but it shows you that you can easily run into a major epidemic here of several hundred cases very, very quickly. And now we also looked at the compensation claims here, and we've published this recently as well. This shows in the early stages, before about 2019, we were just seeing single figure claims, and that rapidly jumped up. Now, we were doing targeted active surveillance here. We weren't just relying on passive notifications. And you'd expect if there was just a bit of a pent-up demand that you'd see a small peak and then things would drop off again. That's not happening here. We're seeing these cases continue to come through. So we think there are still new cases that are occurring due to these very high exposures. And the other important point here, this is something that Karen, who took over from me at Monco, has published around the autoimmune markers. We do these on these workers, and we found that almost 25% have a positive anti-nuclear antibody. Now, and these other markers there as well, these are considerably higher than you would expect in the general population. So, and we've already seen some autoimmune diseases, about 1% of these, but it tends to suggest that people are on the pathway to developing autoimmune diseases down the track. So we shouldn't forget those other conditions, and in particular lung cancer, given its notification as a group 1 carcinogen. Now, there was even more media interest when all of this information was coming out, and the task force's recommendations, of course. It's not often that occupational diseases get onto the front page of newspapers at home. I suspect it's the same here, or be the lead story in a television or a radio news program. But this was happening. There was quite a lot of interest in this, and that was increasing pressure on the government to do something about this. There was also strong union lobbying. This is the CFMEU. The C is for construction. It's a sort of very combined union, but the construction workers, which are largely being hit with this, became quite vocal about it and ran some demonstrations in the major streets, Melbourne, Sydney and other cities around Australia. Now, we didn't have to send in the National Guard, you'll be pleased to hear. But this again was a very important part of the whole lobbying effort to have something done about this particular problem. Now, Safe Work Australia was asked by the Work Health and Safety Ministers. Now, we have, unlike the UK, we have 6 states and territories, and we have a Commonwealth government as well. So there are 7 Work Health and Safety Ministers around the country, and they meet regularly and they discuss various things that are coming up. They were under pressure to do something about this. So they asked Safe Work Australia to do a decision regulatory impact statement, which they took, they asked them at the end of 2022. They took several months to do this. They did it in a very comprehensive way. They did a financial assessment as well of the different options that were available to them, and consulted with regulators, with employers and unions as well. And they came up with what I think was a really important conclusion. They said, however, it is tolerably clear that historically there has been insufficient compliance activities in respect to the engineered stone industry for the level of risk. Further, there has been and continues to be non-compliance with the obligations imposed by the model work health and safety laws by both CPBUs, which is basically employers, and workers. And so they recommended option was option number 1, which was prohibition on the use of all engineered stone. Now, this was only after the various regulators in the states and territories had tried to introduce good dust control measures, but it showed that those were pretty ineffective in getting this down below the workplace exposure standard. So the ministers and some employers then started to get involved. This is Bunnings. Duncan probably knows about Bunnings, but it's the hardware place that all families go to on the weekend for their gardening and building sort of needs, tools and all of that sort of stuff. Very influential in the Australian community. And they said that they weren't going to stock this anymore. They're not manufacturing it, they're just not supplying it anymore. And the same happened with IKEA, which is a Swedish firm. They said, well, we're not going to do it either. The risks are too great to workers. So this was increasing pressure on the government. So the ministers got back together again at the end of 2023, considered the Safe Work Australia prohibition recommendation and all of this other input as well, and decided that we didn't need this anymore. We could rely on other alternatives. So the ban took effect from the 1st of July 2024. Now, the manufacturer wasn't very happy about this. Not surprisingly, they tried a bit of a rearguard action to say, well, we think it can be used safely, but that really didn't carry much weight. But interestingly, after that ban came in, within a few weeks, they were advertising silica-free products, artificial stone. So it shows you that the industry can pivot quickly to make an artificial stone that's silica-free. Now, we're a little concerned about some constituents of these products as well, and I think because they're a sintered glass primarily, but also with many additives. So I think these need some proper review and investigation as well. But I think these arguments about how important it is to have these products really evaporated once the industry then said, well, okay, we'll make something different and do it really quickly. Obviously knew this was in the wind. Look, I'll just whip through this a little bit. We've also done some estimates of the cost of this over the next 10 years or so. We've just had this published, in fact, in the American Journal of Industrial Medicine by one of our postdocs, Dee Tomic. And we're estimating, based on workers' compensation costs, that we're looking at something in the order of $30 million per year on the costs for this, for compensation costs and healthcare costs. Of course, this doesn't take into account the mental health costs, the society costs as well, and all of that, the other repercussions of this sort of epidemic. And there's also been some estimates done that we're looking at a substantial number of lung cancer cases as well. You can argue about some of the assumptions made in this, but I don't think you can argue that it's going to be a substantial burden on the healthcare system in the future. Now, a lot of people think, well, we've got rid of artificial stone, problem solved, we've done a great job, let's move on. That's not the case at all. You can see that we've still got that burden that's going to be with us for many years to come. But the government's really jumped on board with this and thought, well, we've got lots of other sources of silica exposure as well. So they commissioned the Lung Foundation of Australia to do a national action plan for silica from 2023 to 2028. I was on the advisory committee for this. And they came up with a whole series of recommendations about training, about health surveillance, about dust control and other measures. And that's been picked up now by the Asbestos and Silica Safety and Eradication Agency, which is a fairly new body. Used to be just asbestos, but they've had silica added to their brief. So they were a SEER before, and they're still a SEER, just with an extra S. And so they've been tasked with this. I'm on their Silica Advisory Committee for that as well. And I'll just quickly run through some of the things. So we've now established a national registry for occupational lung diseases in Australia. So it's mandatory for silicosis and voluntary for other causes of occupational lung disease. But this is being done now to try and get those early signals of if a case comes up that's got an unusual exposure, maybe this is something we need to have a closer look at. And we've also just about to establish an Australian Centre for Disease Control. This largely came out of COVID. But the one group of non-communicable diseases that they're going to focus on is occupational lung disease. No other non-communicable disease. They're going to run the registry, and they're going to assist ASEA with implementing the action plan to reduce occupational lung disease. There were a whole lot of other groups that wanted other non-communicable diseases to be looked after, but it's the occupational lung disease, which we're really pleased about. We also developed some national guidance for doctors, clinical guidance, not just for screening, but also for managing, for referring, for assessment for other possible diseases, and managing these cases. They're young men usually, about their return to work options. How can they get into another job that's silica free? So there are quite a lot of ongoing uncertainties about that, and those guidelines are currently being revised by a group back home. One of the things that we're very keen on is making sure that we've got highly sensitive methods in the health surveillance of these workers. And we've just published, well, I'm not quite sure when this was, I think a year or so ago, looking at the sensitivity of chest X-ray. And we believe that's a very insensitive measure, especially when it's done by radiologists who aren't trained in picking up those early signs adequately. In the US, they have a B-reader program. We haven't got an equivalent program in Australia, but the radiologists really need to be aware of what those early changes are. They're not looking at it for diagnostic purposes, they're looking at it for screening purposes, and there's quite a difference there. So we've been very fortunate. We've had a very good group of radiologists who've taken that on board and have assisted us with a lot of the surveillance that we're doing. And in fact, their college is now recommending that low-dose CT is really the method of choice for this type of screening. And in fact, it's been picked up by one of the states, which is Western Australia. It's now a requirement there. Now, the other major thing is about research. We were talking before about research priorities. One of the other things that the Lung Foundation was commissioned to do was to run a workshop, and it had over 100 people. That was done about a year ago, looking at research priorities for silicosis regarding prevention, but also research about care for exposed workers. And we've published this recently. I'm a co-author on this in the Medical Journal of Australia. It's just come out recently. So this is really highlighting a whole range of different areas where further research is needed for this particular area. And one of the things I think is really important are these other additives. There have been a few studies now which have looked at these additives. This is a study from, in fact, it's in from the BOHS in the Annals, which did some measurement and also found there were high levels of VOCs, volatile organic compounds, that were given off. It's not just silica, but VOCs were given off as well. And another recent study that was also done by some Australian colleagues in South Australia, in Adelaide, where they looked at some of the metals, and this particular one, cobalt and aluminium, which is components of artificial stone, and found that they had considerable inflammatory effects on macrophages in the lung. So I think the jury's still out on what role these other constituents are playing, but I think we do need some further work, especially when we're looking at alternatives to silica, artificial stone, what these other constituents may well be doing. They may be playing an important role. We've also set up a rapid detection and response protocol. One of the things that became very clear is that even in the early days, there wasn't really a pathway for notifying government about an emerging risk. The government has now realised that, and so again, the Lung Foundation, I'm on the steering committee for this, is developing this. It's due to be finished by the end of the year, to try and set up a system where there's a landscape review done regularly of emerging threats, whether that's through case reports, case series, epi studies, whether it's from clinicians who have just seen a case coming through the national registry that's been set up, or other possible pathways. And they're establishing an evidence synthesis team, which we're pushing really needs to include physicians and hygienists in it as well, to be able to screen the multiple things that they're likely to see come through that landscape analysis. So we're hoping that that will be up and running early next year as part of the Centre for Disease Control, so that we can get onto any new emerging threats at a much earlier stage and avoid, hopefully, those hundreds or even possibly thousands of cases of a new disease. We're also doing a review of the workplace exposure standard. This is part of a suite of standards that are being looked at. We currently have a standard of 0.05 milligram per metre cube. There's a strong push to reduce that to 0.025. And I know that in the UK, you've still got a workplace exposure standard of 0.1. And I don't know whether that's under review, but I'd strongly urge that to be reviewed. Many countries have now at least gone to 0.05. There are some concerns about measuring at that level, but monitoring methods are improving all the time. So I think we need to be ahead of the game on that. So that's kind of giving you a snapshot of where we've been over the last few years in my country. I suppose an important question is then, are we a bit of an outlier? Is it just Australia who's having this problem, or is this happening in other countries as well? We think we probably knew the answer to that, but if you look at the use of artificial stone, this is worldwide use. You can see that the rise on this almost exponential, and is going to continue to rise over the next 10 years or so. It's almost a doubling of use of artificial stone over the next 10 years that's expected by the industry. So this is a substance that's going to be in increasing use. When you've got rapid introduction of a new substance like this, you're going to have possibly less trained workers who are going to be involved with it. And so again, the risk of exposures that are way above the accepted standards. Now, the USA has gotten onto this problem. It's very much state-based. California is the state that's taken most action on this. They've set up some screening programs as well, and they're seeing the same thing that we're seeing. Young male immigrant workers who are developing these silicosis problems. And there was an interesting paper from our US colleagues that said one of the problems that they're seeing is a delay in diagnosis occurred because they're being diagnosed with other conditions. In this case, it's bacterial pneumonia or tuberculosis, of all things. I don't know how they did that, but that delayed the proper diagnosis of the silicosis problem. I think this highlights a problem that we have amongst the medical community, lack of awareness of these, not asking about occupation that we spoke about before. Yeah, let's move on. We're also seeing this in Spain. There have been 46 cases, again, mean age of 33. It's a very, very young group of workers. And in Italy, again, very, very similar spectrum of disease amongst these workers. And in China, and in particular, they did a follow-up of their cohort of patients and found that a remarkable 90% demonstrated significant progress within a 12-month period. So this is not the sort of silicosis that we're used to from other forms of silica. It's rapidly progressive, and we don't really understand the reason behind that at the moment. There's been a review done of silicosis worldwide, and that's again highlighting this as an international problem. It's not just specific to Australia, and these authors were advocating much stronger implementation of control measures. So what about, let's move on to the UK. That's where I am at the moment. So let's see what's happening here. Some of you will probably be aware of this. I tried to get some information about the use of artificial stone and came across this graph, which unfortunately doesn't go before, I think it's 2018, but it shows up until, I think it's, a bit hard for me to read, 2022, I think. But that blue line, the second one down, is the artificial or engineered stone, engineered materials they call it. You can see that the natural stones down the bottom stayed pretty stable, maybe a little uptick recently, but there was a little drop in the artificial stone during the pandemic, but since then it's taken off dramatically. And if that continues, it means there are far more workers who are going to be working with this substance currently and into the future. Now, we talked about SWORD before, and Marty presented some figures from that, and I've pulled out the most recent published paper, which is from Thorax. I think this must have been a conference presentation, an abstract, which showed that there'd been 4 cases up until that period, 2023, of silicosis in artificial stoneworkers. But we then got an update just yesterday that they've now had 43 cases. So you can see that there's been a substantial increase, not quite on the same scale that we've seen in Australia. But of course, you've got to remember, we had a much more targeted screening program that was set up. This is relying on getting to a doctor and the doctor recognising it and then notifying it to the scheme. So I suspect this is a considerable underestimate of the true state of the problem. Then there was Sir Joe Feary's and colleagues' paper that was published just last year, which again had a case series, got a lot of similarities to Ryan's case series back in 2017. This is some years down the track. This was in 2024. I've got an update from the group there, and they've now seen 34 cases. So it's gone up quite substantially over the last 12 months or so. So we're already starting to see that increase in cases. And again, they get their cases through ad hoc referrals. It's not a targeted systematic screening program that's feeding cases to that group at the Brompton. And again, very similar demographics: young age, immigrant workers, small workforces, poor control, short exposure periods that they're seeing. There've been quite a few articles that have been written. This was a letter to an article in the BMJ that sort of highlighted this as an emerging crisis. It did refer to an HSC response that tended to suggest, they've got a good regulatory framework, and that may be the case, but they'll continue to consider options for future interventions. And I think that bit that I've highlighted, I know there are quite a few HSC people here, I think that considering options for future interventions is something that really is really time to do. Unless you can find some evidence that this isn't the sort of problem that we've had in Australia. Again, this is very similar to the Anthony White story, the picture that I showed you before. This is a worker who died here, and there was some publicity about that. It was the end of last year, I think. Then there are calls for the ban. There have been various calls. This one is actually from an industry paper, and one company has decided not to use this. I think consumer demand has dropped off. It certainly happened in Australia. Customers started to say, we're not going to have that in our house, thank you very much, we'll use something else. And I think that might be happening here as well. The BOHS has been fairly active in pushing for this as well. They put this out for improved controls last year. That was over 12 months ago. They were holding off on calling for a ban at that stage. And look, that's what happened in our country as well. In the early stages of people saying, look, let's just get better control in. That didn't work, so we moved to the ban. It's important to remember this is a whole process that we went through. And this was from the British Safety Council, I think just last week, that came out as well. So there's been increasing pressure by a whole range of organisations for more to be done about this particular problem. So I'm just going to finish off with some lessons learned and a call to action. That's what I tend to do these days since retirement. I've got out of the research business these days, more into the advocating business. So I think the first lesson is beware old hazards returning in new guises. And this is exactly what's happened here. This is a new form of silica with other substances that may or may not be, magnifying the silicotic fibrotic process. But we should always be aware of that. This stuff should probably never got onto the market in the first place if there'd been a proper review of that. Take note of early signals. We had some early signals here, the early 2012 paper, the first case report, but it was really difficult to get government to sit up and take attention to this. It took a reputable body like the College of Physicians calling on the minister to do something about this, and the report of the task force to really get this onto the agenda politically. You need a research evidence base. and we were fortunate, our state regulators, both in Victoria and Queensland, set up a targeted screening program with highly sensitive methods which identified these cases and showed what's possibly, it's still an underestimate, but it showed a significant burden from this disease. And we had a coalition of clinicians who assisted with that, respiratory physicians and radiologists, that we really had good contributions from all of those groups. But the fourth point about advocacy needs a broad coalition of support. Unfortunately, science is not enough. We know that from many years of trying to get occupational health issues onto the agenda, you really need advocacy from a comprehensive range of stakeholders. And in the occupational health setting, that's government, that's industry, that's trade unions, and also professional bodies is really important. And remember to apply the hierarchy of controls. This is Occupational Health 101. And what's top of the hierarchy of controls? Elimination and substitution. So that should be the first option that's looked at. If for whatever reason that's not possible, sure, you work your way down. You don't start with personal protective equipment, which is right at the bottom. That's really important. And you need active screening of these workers. Yes, dust control is really important, but look, that's not always going to be possible, but active screening, an active screening program targeted to workers at high risk is really important. It was only after we started to get that information we realised the true extent of this problem. And regular review of exposure standards is important. Exposure, science changes, new information becomes available, and that's certainly happening with us. I know other countries are still using what I think is quite an old exposure limit. And in governments need to invest and act early. You saw our estimate of the likely financial costs down the track. A small investment up front to try and prevent that happening is a big saving in the long term. And avoid complacency. I think we've been guilty of this back in my country, and business as usual approach doesn't work, not with this particular issue. It may with others, but not with this particular issue. So I think we've got to move past that. So I'm just going to finish up with some reflections on what would Roland Lane do, if he was still here. Now, he was a big advocate for prevention of workplace disease. His big interest was lead at that time, which was a huge problem, and he managed to eliminate that from the factory that he was working with and had a bigger impact too more broadly with industry about hazard control. I think if he was around today, he'd be pushing a few buttons here and trying to make some telephone calls to get some action done on this particular problem. So I'd just like to acknowledge our team back at Monash and also our collaborators. We've got a big team of people who've been instrumental in this investigating and advocating in this particular issue. And I think I'll leave it there and take some questions. Thank you.
Out in other countries too, including the UK. I'll open it up for questions. I'll start. I'll start first.
I thought you would.
It's interesting, really, what you said at the end. Kind of like sometimes, it should never have come to the market. If you compare it, I mean, and this is a product, right? It's not a natural. It's not a natural material.
No.
That is kind of like, it's a product it's
made in huge slabs.
Intentionally produced. I mean, can you think of any other product at the moment that is produced that contains 95% of a class 1 carcinogen, and that will be allowed to be on the market?
Nothing springs to mind. No.
I mean, I don't know whether that's a strange kind of comparison, but it's quite unusual, right? I mean, we're dealing with natural products all the time. I mean, we were living around kind of like we're living in, buildings that are made of stone and wood, etc., which are containing carcinogens. But this is product that's intentionally produced.
That's right. And I suppose the one that springs to mind historically are various asbestos-containing products, which again had very high concentrations of a Group 1 carcinogen. And you know, we've moved on from that. We're still having the burden of that. You know, 20 years later, we had a ban 20 years ago. We're still seeing 600 cases of mesothelioma a year. I used to be on the mesothelioma surveillance program. Doesn't show any signs of dipping at all. So yeah, it's hard to believe. And one of the things that we've pushed is, well, let's look at the initial registration of some of these products, and we try and get some red flags. Maybe this is where the AI might come in to help with analysing constituents of various products that are, because there's an application to come onto the market. We don't produce this, we import it all. And that's why the ban was easier for us to do than, say, the asbestos ban, where there was a lot of mining and manufacturing in Australia. But this is all imported. So,
yeah, I mean, I don't think there's any production of.
I don't think so.
It's mainly a Chinese product, I think, my understanding.
Yeah, it's still made in Israel, I gather, although they're busy other things at the moment. But the and Brazil, I think, is another country where it's made.
I just kind of remind me. I mean, I've been involved a little bit in the past about discussion about titanium dioxide, which has been also classified as I think it was a class 1.
Tin oxide.
Titanium dioxide. And
titanium dioxide. Yeah, I think it was. Yeah.
And that caused a big problem for the industry, because you know it is in many different products, which actually, I mean, compared to silica, it's a very, very, you know, low risk, I guess, if you're exposed to that kind of, if you're exposed to similar levels. But it caused a huge problem because it had to go through ACAR, it had to go, it had to go through all the regulatory processes in Europe. And this doesn't have that same regulatory procedure for allowing it on the market, which I think is for a product that's manufactured, I find that quite astonishing. Anyway, I've said it now.
Yeah.
I'll pitch to Malcolm, if that's all right.
Yeah.
So the question, Malcolm, is, let me just, I wonder if you have any thoughts on the process by which the powdered silica quartz is made and what implications this may have.
So this is in the manufacturing of the slabs?
Yeah, I'm assuming so, yes.
Yeah. Well, this prompted the case, that initial paper from Israel where they were manufacturing this, and that's where these workers came from. I understand. I haven't read that paper for a while now, but I expect that the manufacture of these, yes, to be quite a hazardous occupation, because it's breaking down and compounding and then forcing it together. But there must be a lot of dust extracted as part of that. I don't know whether that's done in contained enclosures. I don't really know much about the manufacturing process at all, but I imagine potentially, yes, there would be. And of course, they've got all of the other additives as well. And I'm not quite, presumably they're powders or liquids. I'm not sure, because we don't have manufacturing. I haven't looked at that side of it. But if it was manufacturing, I definitely want to have a look at what sort of exposure levels from the various tasks involved with that, for sure. David. Yeah.
Malcolm, that was fantastic. Thank you. Just looking at your exposure levels for dry cutting, they were like enormous.
Yeah.
So talking to my colleagues in the UK about cases that we've seen in the Gord's group, it's a very inflammatory looking condition, a bit unlike typical silicosis, and more like an accelerated or even an acute silicosis. So is this just massive levels of silica exposure in poorly regulated workplaces, and how cogent is the argument that it's something a bit different and it's got metals and resins and VOCs, because this could just reflect the enormous exposure to silica.
And that there's a strong body of evidence for that it's just a reflection of very, very high silica exposure. There are a couple of things I'd like to point out. One is there's this hilar lymphadenopathy. I don't know if you've seen some cases of that are occurring and seem to be in the absence of interstitial changes. Now, we're not quite sure of the significance of that. We'll need to follow these patients and just see what happens. Is this just an early stage in some? Is it just a massive inflammatory response that's really enlarged? Because they're hugely enlarged in the mediastinum. And that may indicate there's some other process going on. We're not sure. It's not malignant. We know that, but it's certainly different from what you'd see in more traditional silicotic cases. Where I didn't include this, I had to cut down on my slides because it would have been here all night. But we've just published another paper which has looked at asthmatic symptoms and in these workers as well. Now, it is based on self-report. It's not doctor diagnosed. It's largely around symptom reporting and improvement over weekends and holidays and so on. But there seems to be a signal there that maybe, as well as because the silicosis has been huge, maybe these other conditions are being missed. And I think that probably needs a follow-up just to see whether that's occurring. And that might suggest it's some other aspect of the dust cloud that's given off that might be important in this particular condition. But I think it's early stages yet for that. Yeah.
Okay, thank you, Malcolm, for a great presentation of a very sad story.
Yes.
It was 1979 when I started working after my graduation, and the first thing was silicosis.
Yeah.
And I was involved in a great survey of dusty trades in Sardinia, Italy.
Yeah.
And after that survey, my professor said that silicosis was disappearing. There was no silicosis any longer.
Yeah.
And so I guess all over the world, not on the developed world, this occupational health problems were removed. It was like putting the dust under the carpet. Okay, and moving the exposures to developing countries and low and medium income countries. Now, at the same time, the academic occupational health was downsized. And there is no more ability of diagnosis of occupational diseases. So this thing came up and took everyone by surprise. But this is also the effect, in my view, of the academic policy of downsizing occupational health and occupational health in the academy particularly. This is just one note. The second point is that you mentioned about silica carcinogenicity. These guys will not make it to develop lung cancer. And after that, they will say, probably someone will come up saying that silica is not causing lung cancer. They died before that. That's the problem.
Yeah, look, I agree with you. This is rapidly progressive, and they may well die before they've had an opportunity to develop lung cancers. That may be true. We'll have to wait and see kind of what happens with these. We're continuing to follow our cohort. We've got quite a substantial cohort as now. We've been quite successful in getting funding to do that, because I think there are many unanswered questions about the longer term sequelae of these particular workers. It's interesting you say about silicosis. Is a thing of the past. In fact, my first job in occupational medicine was at a naval dockyard in Victoria, where asbestos was the big thing because it was removing asbestos from ships. And we had an asbestos surveillance program, again, looking for pneumoconiosis. And little did I think too many years later, I'd still be talking about silicosis, but here we are. These things don't go away. We did a review for Safe Work Australia back in 2007 around occupational lung disease in Australia. We looked at all the various data sources, compensation claims, any other information that we had available. And one of our conclusions was, and I was tempted to put this into the presentation, but I decided not to. But one of the conclusions we made, it said we can be cautiously optimistic that silicosis is no longer a major problem in Australia, or words to that effect. So these things always come back to bite you, don't they? But, you know, we've got to be eternally vigilant with these things, because they do make a comeback. Once you start to become complacent about it, think that it's we've solved the problem, let's move on to something else, these things have a habit of flaring up again. So we do need to be vigilant. So That's taught me a lesson. I can tell you in my subsequent reports to be even more cautious about conclusions. And of course, Italy's had a long history of pneumoconiosis going right back to the tunnelling, isn't it, through very early stages that prompted the establishment of ICO. So, and you've got some colleagues there who have been very active in this area, trying to get this onto the agenda with the Italian government as well.
Malcolm, I've got another online question, if that's okay.
Yeah, sure.
Far away. Audience. So the question is, what do you think would be a more pragmatic respiratory and radiological surveillance schedule for such products?
Well, I think, yeah, and this is something we're grappling with at the moment because, of course, we're advocating low-dose CT because we want a more sensitive method, and it's been shown to be very sensitive. We've got another project that's been funded looking at or comparing in a more experimental way the CTs versus lung versus chest X-ray. What I showed you was more observational, so it wasn't done in a true trial, but we've got some funding to be able to do that as well, with people blinded to the status of the other imaging method. And of course, CT is radiation exposure, so we do have to be careful about that. But now the imaging CT can be pretty low dose. We're assured by our radiological colleagues. Whether that needs to be done right from the start, I think there probably should be a baseline done on everybody who goes into this work, and probably that should be CT, but whether it needs to be done in the early stages, I'm not sure. And this is something that the team that's looking at the clinical guidelines is grappling with at the moment, and we'll come out with some updated guidance on that probably early next year. But certainly in terms of the non-radiological methods, certainly good workplace history is really important to document what the exposure has been, because I think even with people who've had very high exposures, there probably should be some recommendations to them to say, look, do you really want to continue in this industry given how difficult it is to keep exposures below those exposure standards? I think in terms of the lung function testing, yes, do simple spirometry. Make sure it's done by approved laboratories with trained people who are doing it. When we did our review of the Queensland Coal Mine Workers Health Surveillance Program, we asked the doctors who were doing it about who was doing the spirometry, and in a couple of cases it was the receptionist who was doing it, completely untrained, and a lot of other not health people, but not really trained in doing it, following all the quality control processes that you should go through. So now we're advocating it's all through Thoracic Society accredited laboratories, which have approved quality control measures built in, because if you're going to do it, you've got to do it to a proper standard. That's absolutely crucial. I think diffusing capacity should be done as well. There's also an argument that ACE, which is a marker, may be useful. I didn't present some findings on that Ryan had published around ACE being elevated in the early stages of this condition. So there may be, other markers that are important to include as part of that as well, and also those immunological markers as well. And particularly the ANA. So there may be an argument for including that as well. So I think this is an evolving process. I think it should be regularly reviewed as the science changes, as with anything. But here it's really rapidly evolving research landscape. So it's really important to keep on top of that and make sure that we change those recommendations about what should be done as the science shows us, and make sure that people are trained and understand what they're doing. It doesn't become just a tick and flick exercise, that they really do this in a rigorous way. They interpret the information that they collect as part of the health surveillance and have actions as a result of findings that shouldn't be there, whether it's referral to another specialist or whether it's going back to the workplace and having a look at the workplace conditions there and making sure that all the appropriate things are being followed.
Hi.
Yeah.
Thanks for a brilliant summary of this terrible problem with artificial stone. So I'm Mike Slater. I'm an occupational hygienist. So I'm particularly interested in control.
Yeah.
Now, you quite rightly talked about the hierarchy of control, and Australia have taken a very brave stance in actually implementing what we all talk about, which is
Yes.
prevention being preferable to controlling a problem. But in the UK, there's been a lot of resistance to banning the material like you've done in Australia, and that includes resistance within my own professional body, the BOHS.
Yeah, I know. Well, we're yeah.
Not all of us agree with that. And I'm just really interested to know whether you think that in all situations where workers are exposed to silica containing dust from using engineered stone, is it possible to control by engineering means or whatever? Is it possible to do that? Particularly when we're looking at these sort of small on-site installations.
Yeah. Yeah, look, this was an argument that was put up, and look, there was a debate in my country as well amongst the professionals as well. Although there's been a strong stand by the Australian Institute of Occupational Hygiene, which is the sort of sister body to you. Debbie Glass, who's part of our group, is quite prominent in the AIOH, and Kate Cole is another colleague who's been very strong on this as well. They were pretty united, I think, in the need for this. And one of the issues was, yes, okay, in theory, yes, it may be possible to do. And in fact, there are some workplaces, some larger workplaces that have spent millions on trying to enclose this process and bring in place a whole range of technologies to do it. But it's just not feasible for these small workplaces. It's just not going to happen. And this was part of the thinking around Safe Work Australia when they were recommending the various options to go down. They said that you've got to look at feasibility in these types of workplaces. It's no good saying, oh, yes, look, in theory, yes, of course we can control dust exposure, but whether that's going to happen in practice, I think, is the real question. And those of us who've been around, I'm sure you've been around in many workplaces over the years, we know that, shortcuts are taken, things aren't done as they should be done quite regularly. And given the progressive nature of this particular problem, even some reduction, but not getting near the exposure standard, is still going to cause a major problem, I think, with these workers.
Amy Guy, HSE, I wanted to ask you about implementation and enforcement of the ban, particularly in the smaller end of the industry. How have you had challenges there, and how have you been able to do that?
Yeah, the short answer is yes, because of course there were stocks around where people had imported and they had warehouses. Now, some of the states took a really hard line on that and said, well, that's not our problem. The ban's coming in, that's it. Others did have an extension, some up until the end of the year, at the end of 2024, a short extension to allow for use of available materials that were already in the country. In terms of the enforcement, I didn't show it, but our state regulator, WorkSafe Victoria, did a fairly intensive inspection blitz on these workers, and they found that even after the ban, there were quite a few workplaces that were still doing it. They issued a whole lot of prohibition notices, and some court cases have resulted as a part of that. And so they're keeping a very strong watch on that at the moment. So because, just banning something doesn't necessarily mean that's going to happen. But the key thing is about the supply. So it's got to be brought in. We're an island, so everything's got to be brought in by ship. So it's much easier for us to regulate that supply than it possibly is in a country like the UK or somewhere in Europe, for example, where there's road transport. Yeah. That's true. I think we had that debate before sometime about something else, didn't we? But you have road and rail, don't you? That yeah. the channel. So yeah, there have been some challenges in that. But look, the suppliers have been really good about it because they can see that there are alternatives. So they've pivoted to that really quickly. I mean, the manufacturers made their low silica or no silica substitution, but the suppliers and consumers too, they don't want this stuff. So there have been all those pressures. So I think, yes, there's a bit of kind of implementation, a little bit of a delay there. But yeah, I'm pretty confident that we'll get to a complete, well, we have got to a complete ban now, so 12 months down the track. Okay, Tash.
Thanks, Malcolm. That was fascinating. As you know, it's a subject that's really resonating with us. And actually, your answer to your previous question was very much, how concerned are you about the replacements for this, and what is it in there that is replacing the silica?
Short.
Sorry, it's a different.
Okay. Yeah, well, I think any new product that's made of a conglomerate of a whole range of things needs to be looked at closely. So I'd like to see some experimental work done on that in the first stages, and you know, measuring what's coming out of it. So we don't, when you do this high-powered tools on this, it's high temperature, all sorts of things can come out of it. There can be changes made to the molecular structure of things like dyes and organic materials that might be in there. So I think it does need a proper evaluation. So even though we're happy that the silica part of it, but there may be the substitutes may still be a problem. A lot of it is sintered glass, and they say it's amorphous silica, but I'd still be a little bit cautious about that as well. So I think the jury's still out on that one. Is that quick enough?
Yeah, so I've got one question online for you, Malcolm.
Yeah.
So how important do you think is wider scale screening of respirable silica in workers potentially exposed, perhaps at exposures closer to occupational limits, e.g. via breath condensates?
Yeah, look, I think anybody who's at exposed to respirable crystalline silica at or close to the exposure limit or above, certainly, well, it shouldn't be above to start with, but let's say that they're around that, yeah, should have regular screening. It's a requirement for us under the health and safety regulations that we have in place in all states and territories in our country. I'm not quite sure what the wording is here with yours, but I presume you have fairly similar type requirements. The difficulty is this question of at risk and how that's measured, who decides on that. These little workplaces, they don't know what a hygiene measure means or a level. So I think this is where the government really needs to take more of an active role in going out and to these workplaces and making sure that this is happening and getting somebody who knows about it, who's doing this surveillance. It's really important.
And I'm not entirely sure, but it's only small work cases. Mike, I and Anne went to the town hall in Manchester, which has been over the last number of years, been kind of like, started up again, and it's all natural sandstone. So they can't use kind of like control measures. They can't. And actually, we went in there and we asked, "Have you done any measurements of silica?" They've done no measurements at all. So that's a major project.
Oh yeah, well, sandstone is a really high silica natural stone. Yeah.
Was there one more question that's online, or Neil? Did you have another question, or you've got the final?
Yeah.
Hi, my name is Neil Bourne. I'm Manchester director of the Thomas Ashton Institute.
Oh, right.
And I've just had a message from my HSE colleague, Professor Andrew Curran, from who's the Chief Scientific Advisor for HSE. Both of us would, he apologizes for not being here to hear you talk. He'd really like to have come and heard what you had to say.
Yeah.
Both of us would like to thank you on behalf of the Institute, because it's wonderful to raise awareness of these occupational health issues and something that's very dear to our heart. On a technical level, I'm afraid I'm a humble physical scientist, not a biologist. I'm not on the health side. What I worry about is things like the morphology of the dust that you're looking at. Clearly, you've got micron, tens of micron sized particles in there. That's going to have a huge surface area. Whereas we're surrounded by silica everywhere we go, the glasses we drink out of, whatever. And if I smash a window, I don't worry about silicosis. So is there something in the physical constituents of the dust that is particularly concerning from your perspective in causing these problems? And is that something that, you know, isn't being mitigated in these poorly controlled workspaces where these workers are sadly suffering as a result?
Yeah, no, it's a good question. And I think there's a lot we don't understand about the particle dynamics with this. You mentioned that there is a large, when you've got these very small particles, it's a very high surface area. So these other additives may well be kind of attaching themselves to those external surfaces of those particles. That might be playing a role here. It's difficult for us to know. I don't think the science has progressed enough for us to be able to really come up with some definitive conclusions about that. But I think it's a really important point. Look, one of the other points I should say is once it's manufactured, once it's installed, it's not going to be a problem, only if you do something to it. So, because there've been a lot of concerned householders who had their house made and are worried that they've got this sitting in their kitchen, what's going to do to their kids. I had an email from somebody who was worried about their kids, and they'd been playing in an area where there was some old construction material. I don't think it's going to be a problem. Only if you do something about it. And we've got some regulations that have come in about restrictions on what can be done. If there is work done on it, it's got to be taken out of the house and not done in-house and that sort of thing. So we need to be very careful, because there's a lot of in situ now, artificial stone in lots of houses and apartments around the country. But yeah, the particle dynamics part of it,